Hi, everybody. My name is Nick Johnson from the University of Washington. I'm going to be talking to you today about targeted temperature management at 33 versus 36 degrees. I don't have any relevant financial conflicts of interest. I do receive some salary support from the National Institutes of Health and the Medic One Foundation. My goals today are threefold. I'm hoping that we can discuss the major randomized trials of targeted temperature management focusing on the out-of-hospital cardiac arrest population. I then hope we can talk about some controversies around targeted temperature management dose, specifically target temperature. And finally, hope to highlight an emerging concept, which is individualizing the dose of targeted temperature management based on the severity of the patient's ischemia reperfusion injury. But first, a definition. When we talk about dose of targeted temperature management, we're really talking about two different things. The first is the temperature that we're targeting, the patient's goal temperature. And for most of us, that's usually a goal of 33 degrees Celsius or 36 degrees Celsius, and we'll talk about why. The second component is duration, how long we cool the patient. In our brief time today, we're going to focus on target temperature and leave duration for another time. So as some background, these are what I would consider the three seminal randomized trials of target temperature after out-of-hospital cardiac arrest. The first two, the Bernard and Hacka studies, were published all the way back in 2002 in the same edition of the New England Journal and looked at very similar patient populations. Those are out-of-hospital cardiac arrest patients with initial shockable rhythms, so ventricular fibrillation or ventricular tachycardia. The two trials together randomized just about 350 patients to cooling in the range of 33 degrees versus no cooling at all. And they both found a similar thing. At the time of either discharge or 6 months, neurological outcome was improved among the patients who underwent cooling to a goal range of around 33 degrees. Fast forward about 10 years, and the Targeted Temperature Management, or TTM trial, was published. This was a much larger randomized trial that also included patients with out-of-hospital cardiac arrest, but allowed for patients to be included with any rhythm, both shockable and non-shockable. Although the majority of patients, about 80%, as we'll see, of the patients in the TTM trial had a shockable rhythm. This trial had a different primary outcome, all-cause mortality at 90 days, and found no difference between the group that was cooled to 33 degrees and a group that was cooled to 36 degrees. So all patients in this study received active temperature management. Based on all of these studies, the American Heart Association and other guidelines published in 2015, so after the TTM trial, recommended two key things with regard to temperature management. The first is they recommended that all adult patients with return of spontaneous circulation after cardiac arrest have some form of targeted temperature management. But the range that they allow for is quite wide. Patients can be cooled from anywhere between 32 degrees and 36 degrees based on these three studies. Now, it's important to note which types of patients were included in the TTM trial because there's some criticism that perhaps the patients in the TTM trial were too well. They didn't have severe enough ischemia reperfusion injury to potentially benefit from the intervention of cooling to a lower temperature. Now, these patients were 64 years old on average. Most of them, as I mentioned, had an initial shockable rhythm, about 80%. 90% of these cardiac arrests were witnessed. Almost a quarter received bystander CPR. The median time from cardiac arrest to basic life support was 1 minute, so there's very short no flow time. And then on arrival to the emergency department, these patients had a mean serum pH of 7.2 and a lactate that was 6.7, so not incredibly high, but also not very low. So all in all, these patients had relatively favorable cardiac arrest characteristics, which is one criticism of this trial. Maybe these patients were too well to benefit from cooling. But there are also some theoretical downsides to cooling to a lower temperature. The first one that gets raised fairly often is the risk of infection. There were some small observational studies that were published after the initial two cooling trials in 2002 that showed that perhaps there was more infection when we cooled patients. But more rigorous, more recent studies, including a sub-analysis of the TTM trial, found that there was actually no difference in the incidence of pneumonia or sepsis at 33 degrees compared to 36 degrees. Similarly, there's a theoretical concern that if we cool patients down to lower temperatures, perhaps they'll have more impaired hemostasis, more bleeding, and perhaps a higher incidence of disseminated intravascular coagulation. In fact, in another sub-analysis of the TTM trial, there was no difference in hemostasis between the 33 and 36 degree groups. Electrolyte abnormalities are common during cooling and they're common in critically ill patients. And in fact, in the TTM trial, there was a difference in electrolyte abnormalities, electrolytes requiring repletion in the 33-degree group, with more electrolyte abnormalities at the lower temperature at 33 degrees compared to 36. Similarly, there was a slight increased incidence in vasoactive and inotrope use in the lower temperature group. But these last two are really things that are generally pretty short term and fairly treatable in the ICU. So after the TTM trial was published, there was fairly rapid adoption of the 36-degree goal, and this is true in literature that really crosses continents. This 36-degree goal was pretty rapidly adopted into practice, perhaps more rapidly than a lot of evidence-based medicine enters clinical practice. A big part of this, I think, was the perception that cooling patients to a goal of 36 degrees is perhaps easier than cooling them to 33 degrees and maybe even safer. But a few years after the TTM trial was published, we started to see reports like this one trickle out. This is a before and after study at the Alfred Hospital in Melbourne, Australia, where investigators looked at 76 patients with ventricular fibrillation out of hospital cardiac arrest, about half of whom were cared for before protocol change when they were cooling patients to 33 degrees, and the other half were cared for after the protocol change, where they changed their target goal to 36 degrees. They examined a number of care processes and outcomes. They found that during the 33-degree time period, patients were much more likely to receive active cooling measures. They were more likely to be cooled in the emergency department. They spent more time below target temperature. They had a 20% lower incidence of fever, and survival trended toward being higher in the 33-degree group compared to the 36-degree group, though this didn't reach significance. So overall, there were a number of processes that seemed to get worse after making the transition to 36 degrees, and perhaps a trend toward worse outcomes as well. In 2018, this study was published in Critical Care Medicine, which looked at 9,500 out-of-hospital cardiac arrest patients in the Australia and New Zealand Resuscitation Outcomes Consortium database. And what they did was they examined processes and outcomes around TTM in over 9,000 patients, about half of whom were cared for before the TTM trial was published, and the other half were cared for after the TTM trial. And what they found, not surprisingly, is that after the TTM trial, the average temperature that patients were cooled to was higher by about a degree, and that there was a higher incidence of fever after the TTM trial was published across Australia and New Zealand. But perhaps most concerningly, outcomes for cardiac arrest in Australia and New Zealand, like much of the world, had been improving over time as we get better at providing critical care and understanding prognostication. It's not surprising the secular trend shows improvement. However, after the TTM trial was published, there was this abrupt change in the slope of secular improvement, and outcomes actually began to get worse. Now, of course, this can only demonstrate association and not causation. There are probably other things that changed or happened around this time that we're unable to account for, but it certainly is a concerning trend. We took a similar look at our local outcomes at my institution. We took 782 out-of-hospital cardiac arrest patients who were treated at a single institution. We excluded patients who died in the emergency department or who weren't cooled, which left us with a study cohort of 453 patients, pretty evenly split between a time period where we cooled patients to 33 degrees exclusively and a time period where we cooled patients to 36 degrees exclusively. Patient characteristics were fairly balanced at baseline. The 33-degree cohort was slightly older and had a higher incidence of having a primary cardiac etiology for their arrest, though no significant difference in initial shockable rhythm. We found, not surprisingly, that before the protocol change on April 7th of 2014, patients were cooled to a lower temperature on average than after the protocol change on April 7th of 2014, where average temperature jumped up closer to the 36-degree range. We also found a number of interesting unadjusted outcomes. So neurologically intact survival during the 33-degree period was about 10% higher than during the 36-degree period. Similarly, survival to hospital discharge, which was not statistically significant, trended toward being higher during the 33-degree period. Much like Dr. Bray, we found that TTM was initiated in the ED more frequently during the 36.3-degree period, but the average presenting temperature of these patients was 35.5 degrees, which is lower than the TTM 36 goal, which might explain this difference. We also found that time from 911 call to the initiation of targeted temperature management was faster in the 33-degree group. We built a number of multivariable models during which we adjusted for the following covariates: age, sex, arrest location, whether the arrest was witnessed, bystander CPR, shockable rhythm, and EMS response time. And after adjusting for those covariates, we still found that targeted temperature management to the 33-degree goal was associated with a higher odds of favorable neurologic outcome at hospital discharge. We did not find an association with higher odds of survival to discharge, however. So not long after our study was published, Dr. Lascarou and his group in Paris published a multi-center randomized trial of 584 patients with out-of-hospital cardiac arrest or in-hospital cardiac arrest and an initial non-shockable rhythm, during which they randomized patients to targeted temperature management to a 36-degree goal versus targeted normothermia to 37 degrees. And they found a number of interesting things, one of which I'll highlight here. Overall, they found that outcomes for patients with non-shockable rhythm are not surprisingly fairly poor, with over 80% of patients in each group dying, and many more having poor neurological outcome, highlighted by cerebral performance category scores of 3 or 4 in the blue and in the purple here. They did find, however, that patients cooled to 33 degrees compared to normothermia had a higher incidence of having a cerebral performance category score of 1 or 2, so good neurologic outcome at the time of follow-up. So this highlights this idea that perhaps we were thinking about targeted temperature management the wrong way by including patients with less severe ischemia reperfusion injury, primarily shockable rhythms, in these TTM trials. And perhaps the population we should be looking at cooling to lower temperatures and thinking about a higher dose of targeted temperature management are the ones with more severe injury. Dr. Kelly Sawyer at Pittsburgh also had interest in this question and conducted a sub-study of the amiodarone lidocaine placebo out-of-hospital cardiac arrest randomized trial, during which they included 3,200 patients with out-of-hospital cardiac arrest. All patients in this trial had a shockable rhythm, and about a third were discharged with good neurologic outcome. And what they did was they examined the ratio of hypothermia, so the hypothermia dose, to the time of ischemia, the ischemia dose, and found that this ratio was actually associated with favorable neurologic outcome. But when they broke this down a little bit more, they found that the primary driving factor of this relationship was actually the ischemia time, the amount of time that the patient had low or no flow. So it wasn't necessarily the hypothermia time that was the major driver. So Dr. Sawyer and her team concluded that this ratio is interesting. It's perhaps the case that patients with longer ischemia time might benefit for longer or deeper durations of cooling, but we need to study this prospectively before we can understand whether this is a real therapeutic target. Similarly, this was a retrospective study conducted in Japan, where patients with out-of-hospital cardiac arrest were broken down into subgroups based on the severity of their lactic acidosis after the cardiac arrest. And in the group with the most severe, the highest lactic acidosis, cooling to a range of 32 to 34 degrees compared to 35 to 36 degrees was actually associated with a higher adjusted odds of neurologically intact survival. So again, patients with perhaps more severe ischemia reperfusion injury cooled to deeper hypothermia, potentially doing better than patients who received more mild hypothermia. And finally, hot off the press, just published last week in JAMA Open by Dr. Calloway from the University of Pittsburgh, was a study using the Pittsburgh Cardiac Arrest Registry, where they looked at the Pittsburgh Cardiac Arrest Category Score, a marker of initial ischemia reperfusion severity after out-of-hospital cardiac arrest, and whether there were differential outcomes according to the temperature that was targeted for TTM. So they looked at both survival and neurologically intact survival, which they define as a cerebral performance category score of 1 to 3. The Pittsburgh cardiac arrest category score is a 4-step score. So category 1 is awake. Those patients weren't included because they would not have received targeted temperature management. Category 2 is patients who are not following commands but have intact brainstem reflexes and only mild cardiopulmonary dysfunction, so relatively less ill. Category 3 are comatose patients who have moderate to severe cardiopulmonary dysfunction. And then category 4 are comatose patients who also have at least one brainstem reflex absent. So 4 is more severe than 2. They found that in terms of survival, among patients with the most severe illness, being cooled to a lower depth of temperature was associated with a higher survival by about 10%. And even in the intermediate severity group, the category 3 patients being cooled to a lower depth of temperature was also associated with higher survival. Interestingly, in the less severe groups, that relationship was flipped. And the same relationship was found in terms of neurologically intact survival, being cooled to lower temperature, higher proportion of patients who were discharged with neurologically intact survival. Similarly, in the 3s, and then the relationship again flipped in the less severely injured patients. So we have a lot to learn about ideal targeted temperature management dose. Unfortunately, there are 2 important trials that are upcoming or ongoing. The first is the TTM trial, which is currently recruiting. It's based out of Sweden, but is a multi-center, multi-country study that hopes to enroll 1,900 patients with witnessed out-of-hospital cardiac arrest. They are randomizing patients to 33 degrees versus controlled normothermia at 37 degrees with a primary outcome of 180-day mortality. And the ICECAP study has just kicked off in the US. We hope to enroll 1,800 patients with out-of-hospital cardiac arrest. And the primary outcome, or the primary intervention, is actually TTM duration. So we hope to define both the optimal duration of cooling, but also understand the dose response curve to get a sense as to whether this is overall a helpful therapy. All patients will be randomized to, or all patients will be cooled to 33 degrees, and this is an adaptive design trial that will randomize patients to different lengths of hypothermia, different durations. And the primary outcome is modified Rankine scale score at 90 days. So in summary, the optimal dose for targeted temperature management remains elusive, and we have a lot to learn. Both 33 degrees and 36 degrees, if you do it strictly, are reasonable and guideline concordant, but perhaps 36 degrees is not as easy as we thought. The right answer might be titrating TTM dose to the patient's level of injury, though there are more studies that are needed in this space in order for us to understand if this is truly a viable strategy. Thank you very much.